Alright, so I'm going to start with this next part of the fluid, electrolyte, and acid-base balance chapter. I do want to include that treatment for acidosis or alkalosis, your acid-base imbalances, you have to treat the underlying cause, must be diagnosed and treat. You can give bicarb to correct the acidosis. Now, if an excess of fluid or electrolytes are present, you must decrease that amount, or you must increase the amount if it is low. Okay. Now, let's talk about some factors that would make someone at risk for fluid, electrolyte, and acid-base imbalances. Age, environment, such as a hot weather, sodium-rich diets, diarrhea, vomiting, NG suctioning, cancer, COPD, cirrhosis, heart failure, and end-stage renal disease, trauma, and medications can also put someone in a category as a risk for fluid, electrolyte, and acid-base imbalances. We have the ACE inhibitors, which can cause an increased potassium. We have antidepressants, which can cause hyponatremia. Antacids, which can cause hypercalcemia. We have diuretics, which can cause hypokalemia and hyponatremia. And we have potassium-sparing diuretics that can cause hyperkalemia. And we also have laxatives that people may use that can cause fluid, electrolyte, and acid-base imbalances. Now, if fluid restrictions are ordered for your patient, you want to make sure that your patient understands why. Remember that your patients do not have the medical knowledge that you know, so you will have to explain it in a way that they can understand. Now, if you have a cup that would hold 240 cc's of liquid and it's full of ice chips, you would count that as 120 cc's for the ice. Now, I know in this book that it does go in a little bit with the feeding tubes, NG, and parenteral nutrition, but we went over that in our last chapter, so I'm not going to go over that in this chapter. You will learn about initiating IV lines in your next skills class, but we will talk about infiltration and phlebitis. Now, infiltration is when IV fluid enters the subcu tissue around the site of insertion. Now, extravasation is the technical term when a vesicant enters the tissue. Vesicants would be chemotherapy or vancomycin, anything that can cause tissue damage. Now, with infiltration, we want to look for edema, pain, taut skin, and skin that is cool to touch. For an infiltration, we would stop the infusion, DC the IV, but sometimes with extravasation, the physician might want you to push a certain medicine through that IV before you DC that IV. So you just have to kind of know what is going through that IV and have a good idea of what your doctor would want. Now, you would want to elevate the extremity and do call that doctor if it is the vesicant. Apply warm or cold compresses and start a new IV. Now, phlebitis is when there's inflammation of the inner layer of the vein. Redness, tenderness, pain, warmth, and red streaks are all possible. Red streaks on the skin. Now, for these, we would stop the infusion, DC the IV, start a new line, and offer warm, moist compresses. Now, for blood transfusions, you can look on page 913 in your book. I do want to talk about antibodies. Antibodies function to identify and help remove foreign antigens, or they target viruses. Each antibody recognizes a specific foreign antigen. Antigens are a substance that causes an immune system to produce antibodies against it. I do want you to be familiar with type O blood as the universal donor and AB blood as the universal recipient. Now, autologous transfusions are a reinfusion of the patient's own blood. It can be donated 6 weeks prior to surgery or reinfused from a drain, in which the specific drain is called a Constavac. Now, blood must be given in at least 2 hours, no longer than 4 hours. From the time you get the blood, you have 30 minutes to start that blood, okay? But that 30 minutes is included in your 4 hours. Now, if there is a transfusion reaction, you want to stop the transfusion, run normal saline, notify your doctor, and stay with the patient. Now, you also want to notify the lab, and in most facilities, you'll have to send that blood back to the lab. You can prepare to administer antihistamines, okay? Remember, you want to save all the blood container tubing and labels. Now, there are different types of blood transfusion reactions. We have acute reactions in which the patient can experience chills, fever, tachypnea, hypotension, sudden oliguria, and low back pain. We have febrile non-hemolytic. The patient often experiences sudden shaking or rigors, a fever of more than 1 degree from the start, and muscle pain. We have mild allergic reaction, which is when the patient experiences flushing, hives, or itching. We also have anaphylactic reaction, in which the patient experiences wheezing, dyspnea, anxiety, hypotension. They can even experience shock and cardiac arrest if not treated appropriately. Now that's all of the fluid and electrolyte and acid-base balance chapter. I will start with oxygenation in the next video recording.